Welcome to Medical Logistics 101, Review of Pelvic Pain. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definitions of pelvic pain. Pain arising from structures within the pelvis may be gynecologic, urinary, GI, or musculoskeletal. Acute pelvic pain, sudden onset, usually hours to days. Higher risk for torsion, ectopic pregnancies, ruptured cysts or stones. Chronic pelvic pain, weeks to months, often non-emergent, but not the focus of this overview today. Signs and symptoms, gynecologic. Ectopic pregnancy, usually it's unilateral pain, sometimes seeing vaginal bleeding with that. Dizziness and syncope, sometimes, particularly if it's ruptured. Ovarian torsion, sudden severe unilateral pain with nausea and vomiting sometimes. Ovarian cyst, unilateral pain, may follow intercourse or activity. PID, or pelvic inflammatory disease, typically see lower abdominal pain, fever, discharge, cervical, vaginal. Dyspareunia. Urinary cystitis, bladder infection, dysuria, frequency, suprapubic pain, ureterolithiasis or kidney stone in the ureter, flank pain that may radiate to the groin. Typically we'll see hematuria with that on the urinalysis, as well as sometimes nausea and vomiting in that patient. Signs and symptoms, male pelvic. Prostatitis, you'll typically see perineal and suprapubic pain, dysuria, fever, testicular torsion, acute scrotal pain radiating to the pelvis often. Hernias, groin pain, worse with lifting, straining, severe pain if it's incarcerated, where there's actually a lack of blood flow to that segment of the bowel in the hernia. Exam findings, general vitals, abdominal tenderness, guarding, rebound. Pelvic exam, female, cervical motion tenderness. If you see that on exam, on the pelvic exam, think pelvic inflammatory disease. Adnexal tenderness, cyst, like ovarian cyst, or even ovarian torsion. Vaginal bleeding, I would certainly consider ectopic pregnancy if you do have a positive pregnancy test. Male GU exam, high riding testicle, absent cremasteric reflex, think testicular torsion. Cremasteric reflex can be kind of subtle. It's one of those conditions that you have to have a high index of suspicion for. Tender boggy prostate, think about prostatitis. The rectal exam is very helpful in diagnosing that. Hernia exam, palpable bulge in inguinal femoral region. Pain with a Valsalva. Oftentimes you'll see worsening pain with a Valsalva maneuver if it's a hernia. Differential diagnosis, gynecologic, ectopic pregnancy, ovarian torsion, ovarian cyst, which can be simple, hemorrhagic, or ruptured. Pelvic inflammatory disease. You can also see, less commonly, tubal ovarian abscess on those exams. Male pelvis, prostatitis, testicular torsion, epididymitis. Certainly epididymitis is more common than testicular torsion. Differential diagnosis, hernias, inguinal hernia, femoral hernia. GI mimics, less common, but think about appendicitis, diverticulitis, sometimes constipation, as well as gastroenteritis. Gastroenteritis would typically be more generalized symptoms as opposed to being localized. Diagnostic studies, pregnancy test, mandatory in all reproductive age females, tubal ligations don't count. Ultrasound first line test for torsion, cyst, ectopic pregnancies, PID complications. CT of the abdomen and pelvis, the test of choice for looking for kidney stones, appendicitis, diverticulitis, and also evaluating hernias. It may show ovarian cyst, but it cannot rule out torsion. Urinalysis, infection versus hematuria. Typically we'll see hematuria with kidney stones. STI, sexually transmitted infection testing if PID is suspected. CBC and CMP, just general labs that we normally will do. Certainly you would want that in the event that someone had fever. You may see leukocytosis on the CBC as well as anemia. Red flags, hemodynamic instability or hypertension, major red flag if someone with pelvic pain. Positive pregnancy test plus pelvic pain, think ectopic pregnancy. Severe unilateral pain with vomiting, I would certainly want to rule out ovarian torsion. Fever plus pelvic pain plus instability, think pelvic inflammatory disease or tubal ovarian abscess. Testicular pain with a high riding testicle, think torsion. Incarcerated or strangulated hernia, certainly something to be on guard against. As it gets said, on incarcerated hernia, you can't reduce it on exam. Strangulation is where you have a compromise of blood flow to that segment of the bowel. Obviously, not all hernias contain segments of bowel. Sometimes they're just fat-containing hernias. Peritoneal signs, if you see that in someone with pelvic pain, definitely would be worried about a rapidly worsening condition. Other pitfalls: assuming an ovarian cyst on CT explains the pain. As I said, to diagnose ovarian torsion, you have to have an ultrasound. CT can't rule that out. Treating UTI symptoms and not evaluating for PID. Assuming kidney stone pain in men and having a missed testicular torsion. Sometimes with kidney stones, when they're lodged in the ureter, they will cause pain to radiate down toward the groin area, which could certainly make you attribute the pain to the kidney stone and not realize that they've actually got a testicular torsion. Of course, CT should be helpful for ruling out the kidney stone. It won't rule out the testicular torsion. Checking for pregnancy in reproductive age women. As I said, tubals do not count. Missing femoral hernias in older women. And last but not least, though not often something that you see, missing toxic shock syndrome. Very dangerous condition, particularly if there's a history of these use of superabsorbent tampons. But it is one that you would have to catch early because it is very serious. Disposition, immediate OR and transfer would be seen for a confirmed ectopic pregnancy, ovarian torsion, obviously, testicular torsion, a strangulated hernia, hemorrhagic ruptured ovarian cyst with instability. If they were hypotensive and they had a ruptured ovarian cyst, that would be a reason for transfer. Urgent evaluation, PID with systemic symptoms, obstructing urolithiasis. You can't get the patient's pain relieved. That would be another reason for admission. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.